Thank you. Thank you all for staying around for one of the presentations on what's been a really great day. I have no conflicts of interest to declare. So really the question that we were looking at is when HIV care is integrated into primary healthcare clinics, how is primary healthcare services impacted? We chose to look at this question in South Africa, which has a population of 53 million, and 5 to 6 million of those are living with HIV. We looked at Free State Province, which you'll see here in the orange in the middle of the country, that has a population of 2.8 million, about 20% adult HIV prevalence, and 32% when you look at the antenatal clinics. A little bit about the context. In 2004, HIV care and treatment was brought into the public sector via a vertical system. So as you can see by this diagram, there was a cumbersome referral process between local clinics, treatment sites, and assessment sites. Many of the patients waiting for treatment weren't getting it, and it was associated with high mortality while waiting for treatment, especially for those who were most economically disadvantaged. In 2010, via national policy, all HIV treatment and care were brought down to primary health care clinics. And this was mostly done by nurse initiation, or NEMART, so no additional financial resources were given to the clinics. Additional data entry staff as well as pharmacy assistants, however, were provided. So in our study, we defined integration as the month and year that comprehensive HIV care was available at primary health care clinics. So that means from testing to treatment to follow-up. So how did we measure all this? So we started with 15 indicators of primary health care over 4 years. And these indicators were selected via key informant interviews within the province. We really wanted to capture things around clinic functioning. So for antenatal care, we looked at early antenatal coverage and number of antenatal clients who have had a first HIV test within antenatal care. For reproductive health, we looked at contraceptive coverage. For child health, we looked at 2 indicators, which were immunization coverage at 1 year for both population and clinic level. For infectious disease, we looked at neonatal HIV coverage, as well as percent of patients missing their 2-month sputum sample for the smear-positive tuberculosis patients. For non-communicable diseases, we looked at four variables, and that was new hypertensives on treatment, as well as new diabetics on treatment, both at the population and clinic level. And lastly, for workload and productivity, we looked at things like staff-to-patient ratio, as well as nurse workload, and number of clinic visits per year. So how did we end up with 131 clinics in our study? We started with all the primary healthcare clinics in the province and matched them across data sources. We excluded those that in the previous vertical model got additional HIV resources, and those that couldn't provide at least 6 months of data post-integration. We excluded atypical primary healthcare clinics, those which maybe had NGO involvement or were co-located on a campus with a hospital, or those who catered only to specific populations. We excluded 15 clinics that were missing more than 4 months of consecutive HIV data and ended up with 131 clinics that represented a catchment population of 1.5 million. So here you can see on this table that across the months of the study period, the number of clinics that integrated at each month varied significantly. For our analysis, we used interrupted time series analysis at 18 and 30 months in order to see if the trend before integration changed compared to the trend after integration. So at the clinic level, each month and year the clinic integrated were set as time 0. We also used linear mixed effect models to add in HIV indicators into the model to see if any of the changes we were detecting were actually related to the number of HIV patients at the clinics. And we accounted for multiple comparisons, looking at p-values that were significant to be those less than 0.003. So what did we find? The first thing we found, as you can see in this graph, if you look at the red line, that's the total adults on treatment in these clinics. So we saw an astounding increase in patients in these clinics over a 4-year period. So in April 2009, which is 1 year before the policy was implemented, there was around 1,600 patients on treatment in this clinic. By April 2013, the number was over 57,000, which I think is an astonishing increase. 77% of those, or around 44,000, were actually treatment naive. So what about our indicators of primary health care? What happened there? In these 4 domains of primary health care, we didn't see any significant changes. However, in the areas of child health and workload and productivity, we did. So let's take a closer look at the workload and productivity. So here you can see on the left the 4 indicators we captured. And you can see the clinic visits per person each year changed, which is kind of what we would expect when you're getting multiple things taken care of at one visit, that you would come less often to the clinic. And you can see on the right that that was actually related to the number of new patients and total patients on treatment at the clinics. And how about child health? Now this is an interesting finding because we actually found decreases in both of our indicators at 30 months. So there was a decrease in population level immunization coverage as well as clinic level. However, you'll see that on the right that none of these changes were actually related to the number of HIV patients in the clinic. So there may be something else going on. Let's take a closer look at these graphs. So here, the vertical line in the middle is actually when each of the clinics integrated. So you can see a steady increase at the time of integration and a decrease following integration. When we disaggregated the data, we found that it was only 11 to 13 clinics that were contributing to this change, which represents a decrease of 1 to 2%. So what are the strengths and limitations of our study? One of the big strengths I find is this is a real-world implementation at a provincial level. So we're not looking at implementation done with a lot of external funding from larger global health initiatives, but something that's nationally financed within the limits of the health system. Also, there were a large number of clinics in our study, which allowed us to really see population-level trends. And the longitudinal data really allowed us to see what was happening as the implementation of integration was taking place. However, there are limitations to our study. One of the big ones is generalizability. As we know, South Africa has a very high burden and a generalized epidemic, and is a middle-income country. So how these results would, if they're applicable to other settings, actually needs to be studied. Another limitation is the limitation we often have with administrative data around availability and accuracy. And lastly, by defining integration as just a month and a year where it took place, we were unable to account for changes in HIV patient numbers. For example, when another clinic nearby opened and there was maybe a reduction in HIV patients in that clinic, we were unable to really account for those nuances. So what is the significance and implications of this? Really, I think that in our study we found that integration of HIV care can really rapidly expand access to ARTs with very few compromises to primary health care in our setting. The determinants of some of these changes that we did see in primary health care, especially child health, really need to be explored. And we really need to identify common metrics that we can really use to evaluate integrated health services across various settings. I'd like to remind us that we are really looking at patient-centered health systems, and we really need to engage patients and communities in our research, because patients don't view themselves as one disease. They have multiple diseases and multiple needs. And I'd like to end my presentation today with a short video clip of the patient perspective of integrated care.
They're so expensive for us to buy. The things it was not possible for us to get it. I was like waiting for death and wishing for the best.
And then when they brought ARVs into
the public sector
and then to primary health care.
To primary health care,
yeah. So
yeah.
how was it different before that was in primary health care? What was it like before it was in primary health care?
Before it was scary because we used to see people dying in front of us often. It was depressing. It was depressing. When they brought it on the primary health care, it was very, very, very better. People are now more open. And people are now more encouraged to go for testing and to go for treatment, to take medication, because they can see on other people that, oh, this medication is working, and they can talk more about it. They're no more afraid. Most of the people are no more afraid to talk about it. They take it as any other ailments, any other chronic ailment. Previously, that was like something that's hidden. So now it's like something that's open for everybody.
I'd like to thank all of our participants and our funders for this research. Thank you.